Okay, so we are speaking about thyroid nodules on ultrasound and applying ACR TI-RADS to these thyroid ultrasounds. I speak from the point of view of being on 3 of the ACR's thyroid committee. I started off on the incidental findings committee as a neuroradiologist. These are incidental nodules that you see on imaging on CT and MRI. And they were the nodules that I was coming across because I don't actually do thyroid ultrasound in practice. So it's pretty ironic that I know so much about thyroid ultrasound now. And then after that, I was welcomed with open arms to the Thyroid Lexicon Committee, which is entirely ultrasound, and then eventually in developing ACR TI-RADS, which is the management recommendations. Can people at the other end hear me? Okay, yeah, okay. Can people understand the Australian accent? Yes, okay, good. And then recently we were fortunate enough to receive a grant to actually study ACR TI-RADS even further in a multi-center study and a registry type of study. And this speaks to the fact that the ACR is really invested in ACR TI-RADS because they recognize this is a very big problem in our country, and there is definitely a better way of doing it. So here are some quotes that I want to share with you. These were quotes that people came up and told me after doing some of these thyroid talks at various meetings. They say, reporting is tedious. I'm not adding value reporting and following every nodule greater than 1 centimeter. I'm asked to biopsy all nodules greater than 1 centimeter. We use ultrasound room once a week just for thyroid biopsies. And these are quotes actually from Australia when I went and gave a talk in May. So it's not just a problem in the United States. And I don't know if any of these comments resonate with you. So in May of 2017, this article was published, the ACR Thyroid Imaging Reporting and Data System, ACR TI-RADS white paper of the committee. And this was the paper that took I would say 2.5 years to come into fruition. And this is basically what you do with a thyroid nodule based on 5 categories of findings, whether you do nothing, whether you follow it up, or whether you biopsy it. So we'll go through this in more detail. In this talk, I aim to tell you about essential thyroid facts that I learned as a neuroradiologist that has actually kept me going on this problem, that makes me passionate about addressing this problem. I'm going to talk about the problem with our current practice, and then I'm going to give you a really practical overview of ACR TI-RADS, how to approach it as a sonographer as well as a radiologist. And then I'm going to share with you some preliminary studies that haven't been published on ACR TI-RADS to convince the people who are saying, I don't want to change, what I'm doing is fine. You need to change, it could be better. Does that sound good? Okay, so if you have a thyroid nodule that's solid on ultrasound, like this one, the decision is whether you FNA it or you don't FNA it. Well, when you're making this decision, I think you need to think about it in another way, not just whether it's benign or malignant, but also to acknowledge some essential thyroid facts. And there are 3 thyroid facts that I want to tell you about that I learned when I was writing a paper about 8 years ago. And when I learned these 3 thyroid facts, I really did have an aha moment. I went, what I've been doing about recommending incidental thyroid nodules is so wrong, and I'm causing so much expense and sort of problems to these patients. And so after learning these thyroid facts, I was inspired to take it further. So the first fact I want to tell you about is that in a given thyroid nodule, the risk of malignancy is low. And if you read the studies that are dedicated at looking at malignancy rate on thyroid ultrasound, the malignancy rate varies between about 5 to 12%. And that seems pretty high because as a patient going in with a thyroid nodule, you think, I've got a 1 in 10 chance of this being malignant. Well, those studies have a high malignancy rate because it's a biased sample. If you're going to have a thyroid biopsy, your nodule is already pretty suspicious. So this study showed how low that malignancy rate was. This is a study that was done at UCSF that had more than 8,000 patients, and more than half of them had thyroid nodules. So that's not surprising to you who do thyroid ultrasound because you know this is a very common problem. Well, in this study, they did something different. They didn't biopsy all these nodules. What they ended up doing is they linked the patient's name to a Californian cancer registry. And when they did this, they really found the true incidence or malignancy rate of thyroid cancer, because this was no longer a biased sample. And they found that in patients with one or more nodules more than 5 millimeters, so very small nodules, the malignancy rate overall was just 1.6%.
That's for multiple nodules, or for patients with one or more. Oh, it's one or more. So
yeah.
A single nodule or a patient with multiple nodules?
Yeah, so that the chance of that patient having a malignancy was 1.6%. So the risk of malignancy, if you take all thyroid nodules, is less than 2%. The second fact that's worthwhile knowing is workup is costly and harmful. If we're taking Medicare costs, which are much lower than non-Medicare costs, it's about 7 times lower, and we consider what goes into biopsy, getting the pathology result, the cytology, and the office consult, it actually adds up to $1,059. This is the professional and technical fees of all of those procedures. And then after having the biopsy, there is a chance that the patient's going to have a follow-up ultrasound, a repeat biopsy, or surgery. And why is that? Well, that's because the biopsy result isn't just going to come back as benign or malignant. It's not binary. There's a chance that it's going to be benign, which is about 60%. There's a chance that it's going to be malignant. But then there are these other categories that pathologists use to grade thyroid cytology. And you can see there's a non-diagnostic rate. The other categories are atypia, follicular neoplasm, and then just suspicious. And these categories, the 2 and 3, are recommended for repeat FNA, so that's additional costs. And then these categories, when it's a follicular neoplasm or suspicious, they actually recommend going straight to surgery. And then at surgery, this category 4, which is follicular neoplasm, almost 3/4 of those are benign. And then even if it's suspicious for malignancy, there's a good chance that they're going to be benign as well. So if you think about this table and the fact that there are many nodules, about 1/3 of nodules that actually are not going to be able to be categorized with benign or malignant, then this adds up to additional costs. And this is really the harm in workup of thyroid nodules. I mean, a nodule biopsy is pretty harmless. I know when you guys do it, there's not a high risk of hemorrhage. Patients do pretty well. And the thyroid's so amenable with biopsy, it's so superficial. But the real harm comes to what happens afterwards, particularly when it comes to surgery. So we did a study, and then a surgical journal published a study on patients having FNA for incidental thyroid nodules, and they found, and we found, that 25 to 41% of patients having an FNA just for an incidental thyroid nodule seen on imaging, they go on to have surgery. 25 to 41% end up having surgery because of these results that aren't definite. And then when you look at the Duke patients that have thyroid surgery for incidental nodules seen on imaging, more than half of those are going to be benign. So some of you may look at this and say, well, this is good news. The patient waking up from this surgery is going to feel really relieved that they didn't have thyroid cancer and it was benign and they don't have to have any additional workup. But think about it. They had to go through the surgery, which leaves them with a scar. There are risks associated with thyroid surgery, like vocal cord palsy. This is a picture of the vocal cords. There's a risk of abnormal parathyroid function after thyroid surgery. And then there's the time spent dealing with this whole problem, from the biopsy, additional ultrasound, additional biopsies, and ultimately surgery. And then there's time worrying about this thyroid nodule that they had. So if you think about it, you're putting this, once you start this, entering the patient into this hamster wheel that keeps on going around and around until the end. And then fact 3 is to address the question of, well, I don't really want to miss a malignancy. I don't want to miss a malignancy. I don't want this to come back to me 10 years later and be sued, or I don't want the patient to have a poor outcome if it is a cancer. even though I know the malignancy risk is less than 2%. Well, the behavior of thyroid cancer in most cases is really different to breast cancer or colon cancer or lung cancer. The most common cancers are called well-differentiated thyroid cancers. These are papillary and follicular. And if you look at the 10-year survival rate, it's really excellent. Papillary, it's 99%. Follicular, it's 95%. And this is taking all cancers of all sizes based on the National Cancer Institute SEER database.
But those are survival rates after treatment, yes?
So you're right, Alan. So is that right, Alan?
Yes.
Yes. The question was that the survival rates after treatment? Yes. And we'll address this in the next couple of slides. And this is also the survival rates after treatment based on tumor size, taking all histologies. And if you look at this, can you see how excellent the survival is once your cancer is less than 3 centimeters? It's really when it's 3 centimeters or greater that it starts to change. And now bear in mind that the cutoffs used for ACR TI-RADS and some of the other risk stratification systems are at 1 centimeter, 1.5 centimeters, and with ACR TI-RADS we're pushing to 2.5 centimeters. But look at the survival overall. It's more than 99%. So this addresses Alan's question, what about the ones that aren't treated? Because the SEER database deals mostly with patients that are treated. Well, there is a Japanese study that looked at patients that weren't treated, and this is called active surveillance, where a patient with a small cancer is diagnosed and then they just watch it closely on ultrasound. This is called active surveillance. They found that when comparing active surveillance to the patients that had immediate treatment, the ones that had active surveillance, only 2% underwent enlargement. 0.5% developed new nodal metastases that they didn't have when they had no metastases to start off with. But when these patients who had a change were treated, the recurrence rate was the same. That is, after you treated, the chance of you getting another cancer, that is a bad prognosis. But in these patients, the recurrence rate was the same. There were no patients that had metastases to structures outside the lymph nodes, distant metastases, and there were no patients that died. So in the end, if you're looking at death, or if you're looking at recurrence rate as the end marker, they did the same without treatment or with delayed treatment. And then there's another study, this is from Finland. This was a study back in the 80s where they took patients that had that died from other causes without known thyroid cancer, and they thinly sectioned the thyroid and found that, in fact, 36% of these patients actually had thyroid cancer. They just didn't know about it. So these two studies directly targeted people who asked, what about if you don't get treated? Even if you don't get treated, if it's a small cancer, it's very indolent, and many of us probably have thyroid cancer and we just don't know it, and we're never going to ever have symptoms in our lifetime. So this is another fact supporting fact 3 about the indolent behavior of thyroid cancer, and this is the fact that really got me when I wrote this paper 8 years ago about thyroid cancer and incidental thyroid nodules. This was a study that tracked the incidence of thyroid cancer from the 1975 to 2009. And this is what happened to thyroid cancer in our population in the United States. The rate increased. And you can see that it's not really a linear increase. It stayed actually pretty flat until the 80s and 90s, and then it increased. Now, what happened back then? Yeah, imaging. And so overall, it increased by 3 times, and it wasn't all types of cancers that it increased. It was particularly the small papillary thyroid cancers. So papillary is the most indolent type, and it was those cancers that were less than 2 centimeters that contributed to this increased risk. So what happened to mortality during this time? Because since 1975, medicine's improved a great deal, and imaging's improved a great deal, and treatments have changed. Well, mortality with this increase in incidence remained completely flat. And so this was featured in the New York Times, and it was one of the public's first glimpse of a term that we talk about these days, which is overdiagnosis. Basically, these are not cancers that increased in incidence because of increased risk factors. They were cancers that were always there, but they were increased in incidence because we diagnosed them. And overdiagnosis particularly relates to the fact that you're diagnosing them, but you're not actually changing patient outcomes. But what you are changing is the patient's quality of life, morbidity associated with treatment, and also costs to healthcare. And this was a study that was published in 2016, long after I got interested in this, and I was happy to see this. This was in the New England Journal of Medicine. It talked about thyroid cancer overdiagnosis in many countries, including the United States. The dotted lines here is what was expected in different time periods, but the red lines is what is observed. And at the bottom, we've got patient age. And here, this is a graph that's just showing women. And this basically says that everything above the dotted line here is overdiagnosis. And overdiagnosis is increasing over the years. So the most frequent years, which is 2003 to 2007 here, it's increased across all ages, particularly in women in their 40s and 50s. And they said in this article that the overdiagnosis rate in the United States was 77%. But we really pale compared to another country. Do you know another country that diagnosed more cancers than the United States? Japan, but in particular, South Korea. So South Korea, back in the 90s, implemented a thyroid ultrasound screening program. They have a really great national healthcare system that does breast cancer screening, colon cancer screening, and they said to their public that if you pay an additional $50, I think that was a rough amount of costs, when you come in for your breast cancer screening or colon cancer screening, we'll screen your thyroid for thyroid cancer. And this is what happened to South Korea. So as a result of this increase in incidence of thyroid cancer, overtreatment, no change in mortality again, South Korea no longer offers this program. But I think this is a warning to us of what could happen if we did implement thyroid ultrasound screening. And so the US Preventive Task Force recommends not screening for thyroid cancer at all. So the essential facts, I spent a lot of time talking about it, but I just find it so interesting, and I hope you do too. But we're weighing up detection of malignancy when we're recommending an FNA with the fact that the malignancy risk is low, the workup costs are high, not just monetary, but to the patient's quality of life, and that thyroid cancer is a very indolent cancer, unlike most other cancers, and there's a problem with overdiagnosis. So let's talk about the problem with our current approach. So I worked on the recommendations for incidental thyroid nodules, and I thought that's it. We've got recommendations for what happens when you see a thyroid nodule on CT and MRI and PET. That's all I know about. But then as I was giving these talks, I realized the problem is not incidental nodules seen on imaging alone. It's actually all the nodules we see on thyroid ultrasound. And this is an article that tells us about our trends in the last 5 years. FNAs have more than doubled. This was a study published in 2013, and thyroidectomies increased by 31%. And it stems from thyroid ultrasound reports. We, as radiologists, feel like anything focal is something that we need to report, particularly if it's bigger than 1 centimeter. The biopsy guidelines that we currently have for thyroid ultrasound, there are many. They're inconsistently used, there are many, and they're confusing. There's lack of really strong recommendations coming from ACR until this was published. And we're biopsying and following up too many nodules, and then we're biopsying nodules when they're very small. Now, I know many radiologists at Duke Raleigh use the SRU criteria. And so I wanted to point out some of the weaknesses of the SRU. It's based on echogenic foci, so microcalcifications, whether it's coarse. It's based on composition, so it talks about solid and mixed solid cystic. But that's about it. This was published in 2005 when I was still a resident. And so it doesn't take into the data we have recently about echogenicity, about margins, about taller than wide. So it's a very outdated guideline, although it's really easy to use. And it makes reporting simple, doesn't it? But it's not the best one out there. And then our endocrine surgery and endocrinologist colleagues, like the ones from the American Thyroid Association, because that's their organization. Well, these guidelines were developed without a radiologist participating, and that to me sounds crazy, that you would develop some imaging guidelines about biopsying or follow-up without involving a radiologist. But their system, as you can see, is based on multiple findings altogether. So this patent-based system is confusing, especially if you're not reporting thyroid ultrasound all the time. And then they've actually missed a couple of combinations of findings that other people have written now to criticize them on. They don't talk about these particular categories of nodules. So they are thinking about revising this. So then comes ACR TI-RADS. This was first started off as a paper in 2015, just with a lexicon of what categories to describe based on the current literature. The committee, as you can see, consisted of about 15 members. And then after that was published, we worked on developing management recommendations based on the combinations of those findings. I was one of 6 committee members that broke away from the rest of the committee, and we developed the initial model, and then that was up for discussion, and it really didn't change very much after that. But my input was really in thyroid cancer epidemiology and commenting on size criteria, as well as developing some of the flowcharts. And so this is the flowchart that is associated with ACR TI-RADS. And it's based on 5 categories of findings of composition, echogenicity, the shape of the nodule, the margin, and then echogenic foci. And then each of these categories have findings that add up to a certain point. And the more suspicious the finding, the higher the point. You add up all the points, and that puts you into one of 5 categories from TI-RADS 1 to 5. TI-RADS 1 being benign, TI-RADS 5 being highly suspicious. The key differences is it's point-based, so it's not patent-based, so we're hoping that this is going to be easier for radiologists to use as well as sonographers. That there are higher size thresholds compared to the other guidelines out there. The other difference is it doesn't that there are some nodules that aren't biopsied at all, no matter what size. And then it specifically says that you don't recommend biopsy for more than 2 nodules, and you don't follow up more than 4 nodules. And therefore, you don't report more than 4 nodules in detail.
That's overall, not just per site?
Yeah, overall. And then it has specific instructions for follow-up, whereas previous guidelines just mentioned follow-up. With ACR TI-RADS, there's a strict, well, they're not strict, but some guidelines, specific guidelines on how to follow up. So let's apply it to this nodule that we saw at the beginning of the talk. This is a nodule that's solid. The echogenicity is isoechoic to the normal thyroid. Its shape, it's not taller than wide. The margins are smooth, and it doesn't have any echogenic foci. And so this adds up to 3 points, and this would place it in TI-RADS 3, which is mildly suspicious. And according to TI-RADS 3, you only biopsy if it's 2.5 centimeters or greater, and you only follow it up if it's 1.5 centimeters or greater. So if it's less than 1.5 centimeters, you don't need to mention it in the report at all. So with this nodule is certainly more suspicious looking. It's solid, its echogenicity, it's a very hypoechoic compared to the thyroid, and the same and as hypoechoic as a strap muscle, so this is considered very hypoechoic. The shape, it's not taller than wide. Margins, I can't definitely say it's irregular or lobulated, so I'm just going to categorize it as smooth. And then echogenic foci, there are punctate echogenic foci, also known as microcalcifications, so that gives it a 3. So in total, this gets 8 points, and so this is considered highly suspicious. And you would FNA this if it was 1 centimeter, And you would follow it up if it was 5 millimeters or greater. And if it was less than 5 millimeters, you would not report this.
So you don't report things that aren't getting followed up.
I wouldn't recommend reporting it. We don't say that you can't report it, but why report something that you're not going to do anything about? Especially if you're using a system that is potentially going to take you more time for each nodule, since you're going to look at things beyond just size. Now, this nodule, this is my third nodule. This one is mixed solid cystic, so it gets 1 point. Echogenicity, you're comparing the echogenicity for the solid component. So it's isoechoic compared to the thyroid. The shape is not taller than wide, margins are smooth, it doesn't have any echogenic foci. This gets 2 points, and so I don't have a bigger picture. It's not suspicious, and you would not get an FNA, and you would not get follow-up, no matter what size. Now, if the patient's got symptoms because it's really large, then yes, you might aspirate it for therapeutic reasons, but this is not suspicious according to ACR TI-RADS. Now, these are after the ACR TI-RADS was published, one of the committee members, Bill Middleton, applied it to an old database he had with the SRU, and he worked out the malignancy rate for each of these categories. So TI-RADS 5 is 35%. What we're calling moderately suspicious is really less than 10%, and then mildly suspicious is less than 5%. So with these different TI-RADS, for 5, you recommend a yearly follow-up for 5 years, and then after that you can stop if there's no change. Now this is yearly, this is not 6 months or 9 months or 3 months. This is yearly because nothing much happens with, even if it's thyroid cancer. Remember the 10-year survival rate for something less than 3 centimeters. It's more than 99%. For 4, we recommended it 1, 2, and 3, and then you can skip year 4 and then go to 5. And then for TI-RADS 3, it's every other year, 1, 3, and 5. And people who are uncomfortable with not following up nodules less than these size thresholds, you have to remember the essential facts and how indolent thyroid cancer is. And that was one of the considerations for the committee, a big consideration. If you want to learn more about ACR TI-RADS, there is a website with ACR that has a copy of the actual paper. I put out a YouTube video that I can send to Morgan and he can share with everyone else about an approach. There is a atlas that I can share with you as well. And then, this is hot off the press, we're having a webinar on the 21st of February. I think you should get popcorn for the whole department, and you can sit down at 1 o'clock and block out your patients and listen to the webinar. How does that sound?
Right.
Yeah, okay.
Beer or just popcorn?
Whatever you like. You know, I'm from Australia, so I would get a glass of Shiraz. But none of this beer stuff. Okay. All right, so that's sort of the practical side of ACR TI-RADS. And do I have time to continue on for a little longer? Okay. So after it was published, I looked at some of the forums, which included ACR Engage and also Art Mini. And these were some of the comments that we received. Someone's in private practice, most of these people were in private practice, said, "These RADS schema are metastasizing. It's difficult to keep track of all of them." And they're referring to BIRADS, LIRADS, PIRADS, yeah. But I think it's great that they're metastasizing, personally, because it makes us all better radiologists, because we're all reporting the same way. A patient coming in for an ultrasound isn't going to get a different recommendation because I report it or Alan Rosen reports it. They're going to, if they're following the RAD system, they're going to get the same recommendation. Someone else said, yet another useless classification system that academics have put together to supposedly program us. Oh, this hurt, because I spent all my summer of 2016 on this. But I thought it was funny at the same time. And then the other comment is, I think if you can pick a system and consistently apply it, you are way ahead of the game. Does it really matter whose system you pick? And they're referring to the fact that maybe they've been using the SRU for a long time, or that they're using the ATA because their endocrinologists like it. Why do they have to change now, just because ACR put out another set of guidelines? Well, this leads me to talk to you about some of these preliminary studies. And one of these studies, our own Bobby Vogel was involved.
All right.
Yeah.
We didn't know that. I'm so glad you told us.
So he's the expert now. Everyone look at him. So this first study took 100 nodules and it put the nodules on a ACR website, and we got radiologists to look at these 100 nodules. But first of all, we got 3 experts who were committee members to look at the nodules. And they classified the nodules according to the 5 categories. And based on their categorization of the 5 categories of findings, then we applied ACR TI-RADS to see how many of these nodules would have been recommended for biopsy. And it turns out that 55 of these 100 nodules, which were all biopsied in clinical practice, so these are the more suspicious nodules, they would have recommended 55 biopsies out of these 100 nodules. Then we looked at the other systems, the ATA, the SIU, there are Korean TIRADS and French TIRADS. And so how many nodules would have been recommended by these other systems? And it ranged from 70 to 83, but definitely more. And so ACR TIRADS resulted in a reduction in biopsy by 21 to 35%. That's a good number of biopsies that are not patients that don't undergo biopsy, don't get charged for it, and undergo that $1,000 cost to the healthcare system, and they don't have to worry about their results, and they don't have to come back and try driving through the traffic at Duke Raleigh. But then if you're recommending fewer biopsies, are you missing cancers? Well, actually, no. In fact, the SRU missed an additional cancer that the others didn't miss. ACR TI-RADS performed the same in terms of detecting cancer as the other guidelines. But because it recommended fewer biopsies, the specificity was much better. It was more than 50% compared to SRU, which is 30%, and look at ATA, it's only 18%. And so the overall accuracy of ACR TI-RADS was higher than the other risk stratification systems out there. But this is experts looking at thyroid ultrasound. So then we asked 8 other readers to look at these thyroid nodules on the ACR website. And this is an article that's now been accepted in radiology. And Bobby Vogler was one of those radiologists. We had 6 private practice radiologists who had no fellowship training in thyroid ultrasound or body imaging. And then we had 2 academic radiologists who did do thyroid ultrasound. And we asked them to categorize the 5 features in each of these thyroid nodules. And we also asked them, would you recommend biopsy? What are your own recommendations based on your practice? And this study was cleverly done at a time that people knew about the lexicon, but they did not know about the management recommendations. So they weren't able to look up what ACR TI-RADS was, because we really wanted to measure change. And so when the radiologists were left to their own systems before ACR TI-RADS, they would have recommended on an average 80 biopsies. With ACR TI-RADS, it was 57. So a reduction if they had followed ACR TI-RADS but was categorizing nodules their own same way. So this is regardless of whether they categorized the nodules correctly. If they used ACR TI-RADS, they still would have had a reduction in thyroid biopsies. And you can see that 55 is actually performing pretty much like the experts who recommended, 57 is much like the experts who recommended 55 biopsies. So it can make you all into an expert. What I found really interesting, and I'm showing you this graph because I just love visuals, is we also asked the radiologists to tell us what level of suspicion do they think the thyroid nodule lies in. And we asked them out of 5, and we gave them the description of benign to highly suspicious, but they did not know that this was ultimately going to be TIRADS. And so left to their own opinion, most radiologists in red put most of the nodules in the 3rd category, mildly suspicious. And if anyone says that radiologists don't hedge, well, this is the sign of hedging, because when you're uncertain, you're not going to come out and say it's highly suspicious, but you're not going to say it's benign, you're going to put yourself in the middle. But with ACR TI-RADS, these in blue were the actual categories, and it actually put more nodules in highly suspicious and moderately suspicious. And this makes sense because these 100 nodules were all biopsied. So this is a biased group of nodules that were more likely to be highly suspicious or moderately suspicious. Isn't that interesting? Okay, so how did it perform if it recommended fewer biopsies? Well, the sensitivity of the radiologist as an average was high, 95%, because they were recommending a lot of biopsies. The specificity, only 20%, and accuracy, 28%. With ACR TI-RADS, their sensitivity dropped a little bit, but their specificity markedly improved, and so did their accuracy. So forget about machine learning. Just applying a RAD system makes you a better radiologist, even if there's high variability in what you're calling the features as. So even if you're not good at calling features, which these 6 private practice radiologists weren't, you're still going to come out being a better radiologist in terms of determining which nodules should have biopsy or follow-up.
What's your guess for why that is?
I think that radiologists who aren't certain are going to err on the side of recommending biopsy, particularly when you sort of reach a size that makes them uncomfortable, like 1.5 centimeters or 2 centimeters. Yeah. Do you think so? Yeah. Okay. All right. So then there's this other study that I did, and I partnered with RAD Partners, which is a big private practice group. And once again, I captured this opportune moment before ACR TI-RADS was published. So this idea came about at RSNA in 2016. I met with them and I said, let's do a study within your group. Let's start with phase 1, what you're currently doing with your thyroid ultrasound reports. Then let's implement in phase 2 a structured reporting template where radiologists have to describe these 5 features. And this lexicon was published in 2015, so there was a paper on it. And then in phase 3, I know ACR TI-RADS is coming out in probably the spring of 2017. When it comes out, then do phase 3 where the radiologist now gets the management added on to the structured reporting template. Well, what were the results? They were not what I expected. So here we have a graph that shows what the radiologist recommended for 71 nodules in each phase. And they weren't the same nodules. The dark blue is in phase 1, the light blue is phase 2, and the phase 3 is gray. So in terms of their recommendations for biopsy, it actually didn't reduce, having management recommendations did not reduce the number of nodules recommended for biopsy. It wasn't statistically significant, but it was actually a little bit higher. So I honestly thought that having management recommendations would reduce the number of biopsies. But what it did help with was this category where the radiologist just reported the nodular impression and didn't say anything about it. They didn't say whether it needed biopsy or a ultrasound follow-up or whether the nodule could be just left alone. They just said nothing. And so when a third of your reports don't say anything, then what do? Well, the patient's left wondering, the nodule, they didn't say anything, but it's 1 centimeter. Should I have a biopsy anyway? And the primary care physician, he doesn't know, so maybe the patient's going to be referred for a biopsy. And I don't know if you come across any of those patients. But with ACR TI-RADS, with the RAD system, only 6% did not have a management recommendation. Then the other part of this study that I really love is what it does to the quality of the reports. In phase 1, when it was just free text, because you don't have a checklist, radiologists, none of the radiologists talked about shape at all. Only 8% of the 8% of the nodules had a mention of margins. Echogenic foci, only 14% had a mention of echogenic foci, and the composition and echogenicity were reported more often, but it wasn't really consistent. Now, this leaves you to question, were they not reported because they weren't there, because suspicious features weren't there, or were they not reported because they didn't look? And what do you think? It's probably a bit of both. Yeah. But in phase 3, all of the signs were reported. So then what I did was I looked at the prevalence of, or the frequency of these suspicious findings. So taller than wide shape, which is a really, really suspicious finding. In phase 1, no one reported it, but in phase 2 and 3, the frequency of these findings wasn't 0, it was up to 8%. A suspicious margin, so this is if it's irregular or lobulated or there's extension outside the thyroid, it was only found in 1% of the nodules in phase 1 when there was free text, and the margin was only described in 8% of cases. But a suspicious margin was seen in 6 to 12% in phase 2 and 3, so that for sure was a sign that they didn't look for it, and so they probably missed suspicious margins. And so this made a difference to the TIRADS points, because if you're not seeing all the findings, then your average TIRADS point is going to be lower. And this is a difference between a TIRADS 3 and a TIRADS 4. So this is why we didn't recommend fewer biopsies, because radiologists were actually seeing more suspicious findings that made the patient need a biopsy. So these are the 2 main preliminary studies, and there's going to be a bigger and better study, and this is through the work of this grant and through developing this TIRADS research registry. And through that, I've actually become very in tune with the obstacles that face radiologists when implementing ACR TI-RADS. I've answered really a lot of questions, even though I don't do thyroid ultrasound in practice. And so I'm hoping to answer your questions, but to first summarize, thyroid nodules have a very low risk of malignancy, but the workup is costly and harmful for a cancer that is very indolent. We really need to change the culture of how we're doing thyroid ultrasound if we don't want to continue seeing FNA increasing, doubling every 5 years, and thyroid surgery increasing as well. We have to move away from reporting every nodule and biopsying nodules just because of size. ACR TI-RADS makes a significant improvement on what we're currently doing if we actually all adopt it. It reduces the number of biopsies we do, it improves the accuracy, and it improves on the quality of our reports.